or ineloquent areas that increase the risk of the complication, or the patient become not candidate to the surgery. Also, the situation of the infiltrative injury can be diffuse or pure delimitate. The localization of the eloquent areas in pathologies that deform the anatomy sometimes is unknown because it's in other conditions, is in a known in a normal situation. And the other challenge is that the postoperative neurological deficits range from 4 to uh, 16, 17, sorry, for periorlandic glioma. So this is a critical area. And we know that there are different approaches to try to identify before the surgery and during the surgery, what is the area that is affected by the disease, where are the limits, uh, and you can see in this nice slide, different techniques using biomarkers with the special microscope, new advances in neuroimaging, mapping using transcranial magnetical stimulation, or angiograms before, during the surgery, just to try to preserve the normal brain areas and reduce the comorbidities after the surgery. So, however, still there are considerable high rates of the complication because it's not possible to implement all these techniques at the same time, and or not all the patients need all these kind of techniques. So we need to customize what is the best strategy for each patient. This is also from intraoperative monitoring. We can offer different techniques in patients with supratentorial tumors. One of these is the localization of the central sulcus using the somatosensory evoked rotation and phase reversal. The direct electrical stimulation of the supratentorial motor structures. We can offer cortical and subcortical motor evoked potential and the EMG free. The direct electrical stimulation of language areas basically is a cortical and subcortical mapping electrical stimulation, and using the post-discharge monitoring and epileptiform activities, not only for the epilepsy surgery, also for the mapping, simultaneously with the other techniques, with the intra-electrocorticographic recording or EMG free. You can see in the other part of the slide the advantage, the information that we can provide to the surgeons or the team is in real time. They are not affected by the brain shift that is unfortunately in a situation that happen usually when the dura is open and the tumor is starting to remove, of course, change the anatomy, even if it's abnormal anatomy, comparing with the previous MRI in the neuronavigator. So the nervous system is directly evaluated. In some cases, is the gold standard to evaluate the function of the central nervous system, having a very exclusive spatial and temporal resolution, and it's possible to do the distinction between which is the primary area or the secondary area that sometimes is not easy to define in the functional magnetic resonances. It's possible to do the subcortical mapping during the resection, and from the research, the connectivity and plasticity is possible to evaluate in vivo in humans. So it's like an experiment, and it's very nice to see how the brain responds in unusual situations. So to begin this broad area, we are just to mention the pioneers in intraoperative electrocorticography. You can see Dr. Jasper and Penfield from the National Institute of neurology in Montreal. And still we have this kind of the montage with the cooperation between the neurophysiologists, the surgeons, the psychologists, neurologists evaluate the patient. And now we're sharing this kind of the electrodes. This is a different stereotactic montage using these electrodes applied directly to the cortex. But now we use in America grids, subdural electrodes, or these strips, or a combination. And now we are emerging the stereo electroencephalography, and it's possible to implant uh, to the presurgical evaluation similar that you see at the beginning with Dr. Penfield to decide which is the area more affected. And you can see now one patient in the resection 1 and 3, and the lesion, the collocation of the localization of the grids, and the presence of the spikes. I'm going to use the laser. Sorry. The spikes in this area, and then again, and the resolution in space is only 1 second here. So you can imagine this is 1 second. So it's in real time, and we can detect and mapping in this grid the area that are more irritable, and then the area around that spread these epileptiform abnormalities, and how is possible to see after the resection of the pole that the huge abnormality that is located not in the all the pole of the temporal lobe, is just in the inferior temporal lobe gyrus. So it's possible to guide the resection not only to the resection of the lesion, also to provide a better functional outcome. So in this case, you can see using this grid with this lesion, it's a focal lesion, in different views. And then it's possible to capture some of these elements like this. You can see here the continuous epileptiform abnormality without any clinical manifestation of the patient because it's under anesthesia. This is a ictal event. Electrographic seizure is the other name. And then I stop, and you don't see anymore. So this is the area that is intended to resect, because otherwise the patient is possible to continue seizing after the surgery, even if the resection was removed. So it's two criteria: oncological approach and functional decisions. So using this electrocorticographic recording is possible to improve the prognostic in temporal lobectomy, but also in other kinds of the surgeries. For example, in this graph, you can see the good outcomes, and the good outcome mass electrocorticography is the highest level of evidence is in temporal lobe, and then in the frontal, parietal, hippocampus, and the occipital area. And comparing with the patient that use these techniques versus the others that they don't use that during the surgery, you can see on the long term how they have a better outcome comparing with the no echo. So in summary, the useful of the intra-electrocorticographic in epilepsy surgery is improve the prognostic in lesionectomies secondary to the lesion epilepsy or in patients with negative MRI. Guides the extension of the hippocampal resections because it's different from left to right, and depend also from the presurgical information. And also is a standard, or in optimized lobectomy with this standard approach is possible, but no, is useful in corpus callosotomy. So the other area is the electrical cortical mapping. You can see that they are different approach, different resection, different localization. So in summary, each patient is unique. So we need to provide the signature of the function for each patient. So the books are the simplification of the anatomy and the fusion, but in the real life, each patient is relatively unique, like the Watson Crick say one day before to win the Nobel Prize. So to start, this is the Brodmann maps that was described several decades ago. And you can see the primary areas that many people in this audience know about the primary motor area, the Broca area, another that relevant like the Wernicke area, visual primary cortex. But now the current knowledge only provide us the basic techniques to evaluate this area, but not the other area that is active field of research in neurophysiology to try to mapping other areas that are involved in the thinking or the memory or the interconnection between those areas. So uh, currently, even with this advantage, it's possible just to mapping some of them. To start with the localization of the central sulcus, we use somatosensory evoked potentials, stimulate one side and capturing the signal in the other side because usually the patient is operating one side, no bilateral, but of course it's possible. If it's this situation, maybe we need to implement bilateral stimulation. But in this case, that is the most common scenario, we apply peripheral a stimulus in the medial nerve, and then we try to detect using this strip over the somatory motor area to decide where is the central sulcus. Because even this basic question, sometimes it's not easy to identify because the tumor can induce a distortion of the anatomy. And when the polarity change, you can see here this weight is up and the other are down. In this area, it's possible to localize the central sulcus. No? And you can see the localization of this strip. So now it's possible to decide which is this area to try to preserve anteriorly the motor area and posteriorly the sensory. So it's also easy to see in this area before to the resection using two different montage. This is the 7 contact strip in the referential montage, and the other part is bilateral bipolar montage. One, uh, two to contact, two to three, three to four, and also you can see the change of the polarity to identify which is the central sulcus. So they are factors that affect the ability to obtain the false reverse, and you can see the post-central lesion, edema, and invasive pathology decrease the rate of this obtain of these results. So that means that the area still is so damaged. And the time that we need to maintain this recording to obtain the central sulcus. Even it looks so simple, take 20 minutes to obtain the central sulcus. So we need to become patient. Also, they are on a history, you can see here, about the mapping of the motor and the language mapping. So they are the evolution from the A to D using different knowledge to try to test different areas, connection. Uh, this is the comprehension, repetition, is the emission of the language, or is the just the motor area in related with the speech. So they are complex circuits. It is possible to evaluate using electrical stimulation. So the Basic of the cortical electrical stimulation is shown in this graph. You can see the electrodes can be anode or cathode, but the idea is to despolarization of the neurons. But it's not so simple because the neurons are not in the same direction or position, and the gyros include other level of the complexity. But the idea is to stimulate and depolarize this area or interrupt their function. No, we are not looking for the hyperpolarization because the idea is to become inhibition. However, preoperatively, it's possible to do both. No, the interruption of the function is other theory behind the electrical induced aphasia by electrical stimulation. So we use two techniques to apply the electrical stimulus directly to the cortex. The Penfield technique that uses a high frequency of the stimulation, or the new one, the multiple strain. And you can see the number of the impulse is close to 60 hertz. But then the other techniques is just using short trains of five stimulus and then a long period without any stimulus to try to replicate the motor, particularly the motor response. But how I say they are different kind of the electrodes, so the different effective surface, the current that we usually use in milliamperes, and the train duration. And you can see in the Penfield technique, the thresholds to induce the motor response is using only 3 milliamperes, or the sensory response using similar 3.8, or the post-shock output using 4.8 milliamperes usually. So in this graph, it's possible to see that using the same strip, uh, after the identification of the central sulcus using the somatosensory evoked potential, now we can apply directly the electrical stimulus and then induce in the opposite side, of course, using this theoretical knowledge or visually, see if the patient have this tractography, to induce an evoked potential recording from the muscle in the opposite side. So the same strip is possible to use for both. You can see here the M is from motor area, then sensory. And then it's possible to preserve because you can say to the surgeon, okay, this is the primary motor area from this part of the body. So please don't touch because if not, it's possible to get a decrease in the function. So this is in the real world using the strip, and then we apply the stimulus, and you can see the responses in the anterior tibialis or in the toe of the patient or in the digiti mini. Mhm. So and it's preserved. No? Using in the other area, you can see the free MG. This is the motor evoked potential and the resection of the tumor in an eloquent area. In this eloquent area, because it's so close to the resection, the strip. So now I'm going to show some videos about the different combination is possible using electrodes, or in this case that we are not using electrodes or needles on the hand. No. But we apply the stimulus electrically and the opposite side under general anesthesia. The patient is not aware. No. 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 Now I see 3 milliamperes. No. No. Ah, sí, 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 tuvo la pierna. Sí, tuvo la pierna. Sí. Sí, la esperamos, ¿no? Entonces. So it's take time to localize, and there are different basic movements induced by the stimulation. So I'm going to show other. Now, during the language mapping, you can see now the automatism of the motor tone. And because it's the stimulation, like the surgeon say, the opercular frontal area that induce this kind of the movements. So this is the operative after the resection of the huge tumor in this patient. So some factors affect the obtained direct electrical cortical response. For example, the use of inhaled anesthetic, obtained a flat EG during the mapping. Uh, like I told you, the injury near to the local area, that's possible to avoid sometimes, edema, or the temporal cortex. So in this study from Saito, from Japan, in Tokyo One Medical University, during open craniectomy to preserve the motor function in this patient with the supratentorial tumors, they get the extension of the resection using these techniques in uh, almost all the patient. And the factor that affect the ability to record this electrical response is the older age, uh, greater tumor volume, and the localization in the precentrical gyrus. No? So this is the risk factors to obtain these kind of the signals. So there are alarm criteria that are used the neurophysiologists to detect when is possible to see the potential damage and to alert to the surgical team to reverse the maneuver, stop, or using other strategies to improve the signals. So now we are going to see the mapping of the language by our psychologists. So in this patient having a Wernicke or sensory aphasia, and we use at the same time the electrocorticographic just to see if the stimulus is or not active, and if we can see after the charge during the stimulation, because we see after the charge the mapping is no good performance because it's spread and it's a lot of the energy that is spread is not focal the stimulation. So in language mapping, is also needed the Penfield bipolar method because the other multiple strain is not adequate for this kind of the mapping. And how this slide mentioned, the essential language area can be less than 2 centimeters square or have different sites. Depending on the patient have different language, or depend on the lesion because it's a perinatal lesion and then learn after this lesion, maybe it's in other area. No? So also is possible to see this kind of the complication. or stimulation.
No. Ahí. Lengua.
You can see that on the tongue, it is moving with the electrical stimulation, so it's very focalized the area.
¿Sí está grabando?
Mhm. So we can identify small structures with high representation on the cerebral cortex. So the idea is simultaneously have all these techniques together in our screen to share with the surgical team and using the video, the sensory mapping, the electromyographic evocate response of EMG, motor mapping, and electrocorticographic recording active at the same time for each patient. So with this is possible, I apologize because it's also in Spanish, to have this idea.
Y empiezan la avioneta, por favor. ¿Ves, Daniel? Aquí fue interferencia con la denominación. Esta fue área motora de la cara.
You can see the face area,
Hubo una contracción de la cara y la mano.
face construction of the arm and face.
Se diseminó de la cara y se diseminó hacia la mano. Esto fue interferencia en la comprensión. Todas estas interferencia en la comprensión.
Sensory aphasia,
Incluye T1.
T1,
Donde encontraste actividad.
and epileptic 4 activity in 2 and 3 without any involved of the functional area.
De entrar para buscar memoria acá abajo. Antes se ha reportado en la cara ventral temporal. No. Entonces, lo que, si gustan, ahorita hago el abordaje de T2.
So with this information now and place for each patient before the resection, now the surgeon having a broad vision about what are the functional area, what is the surgical strategies to improve the outcome with the less comorbidity. Okay.
¿En qué lugar podemos comprar medicina? Okay. Listo. ¿Para qué usamos zapatos? Bien. ¿Para qué usamos una cubeta? Para agua. Bien. ¿De qué color es el cielo?
So now you can see he interrupt the language. So he has a motor aphasia. Okay. Okay. Some of them, sometimes the patient, I'm sorry, have during the mapping seizures. So we need to be careful and prepared to this complication of the surgery. Because the incidence of the intraoperative seizure is high, and several factors are related with the intraoperative seizure, like the frontal tumor, neocortical infiltration, low-grade tumors, previous history of the epileptic seizures, or use the Penfield technique. And this is some of the strategies to prevent these intraoperative seizures. But also it's important to know that this kind of seizures don't impact the prognosis of the patient. Also, you can see in some of this video, the patient is awake during the cortical mapping, and they are analysis of the pros and cons, no? Because not all the patients are candidate to maintain awake, especially if the patient have psychiatric condition or is children or is high risk of the airway. It's not possible to try to do in a way cortical mapping. This is dealing with the anesthesia team, but we see the pros to use this kind of the anesthesia. Okay, so even if we compare the awake cortical mapping versus general anesthesia, in patients with gliomas, it's better to have the early postoperative motor outcome. Of course, the duration of the hospitalization is shorter, but interesting, the similar rates of the complication in gliomas and the survival-free state is similar, lower costs, and the complication during this mapping is relatively low. Okay, for this general anesthesia is needed a propofol, opiate, or fentanyl, for example, no muscle relaxant, and avoid the gases. Okay. There are other areas that is possible to test, but are more in research field now. But then sometimes we use in the clinical settings, no? Like this patient, we using this cortical stimulation, we're recording using a grid and the occipital areas to promote the bulk potential, visual bulk potential, and preserve and identify the B1 area to decide if the patient can be resect the lesion without any postoperative injury of the cortical visual regions. Okay. There are other techniques like this, subcortical electrical mapping, to try to localize the distance between the resection and the spinal motor tract. So we have a linear relation between the intensity of the stimulus and the distance to the cortical spinal tract. Of course, it's possible to evaluate using simultaneously tractography, but remember the gold standard is still the electrical stimulation. Okay, so this is just to finish. There are some publications written by neurosurgeons around the world to emphasize the use of these IOM techniques during the resection of the lesion in eloquent areas. And you can see some relevant words like safe, prevention, motor preservation, identifier, reliable, maximize resection, safety in different scenarios. Just to summarize that the implementation and use of these techniques can increase the rates of good outcome in each patient. Okay, thank you so much.
Thank you so much, Doctor. We have no questions in the comment box, but I would like to say that this was a great presentation, and I'm sure we all learned new things. And thank you very much, Doctor, for giving us a moment of your time to share your extensive knowledge. And I hope to have you here with us for our next Congress.
Thank you so much. It was a pleasure. And if the audience have some question, I can answer, and we're happy to answer by the social media or by my email or other ways that you decide. And thank you so much again. Great. Have a great.
Okay, we're going to end the transmission now. And thank you so much, Doctor.
Thank you. So now we are offline. No?
I'm not sure, but we can wait a moment.
Okay.
Ah, listo, ya estamos.
Okay.
Ya se terminó de transmitir. Pues muchas gracias, doctor.